Today I'm going to go over the orientation skills validation checklist. So this will be a bunch of skills. We already did the medication one. So first thing I'm going to go over is PPE or personal protective equipment. So we use PPE when we have someone who is sick and on isolation precautions. So typically when we have someone on isolation precautions, we will have a 3-drawer kit outside their room that has the masks, gloves, goggles, and gown. So first I'm going to put on, each style gown will be a little bit different, so I'll go ahead and put my gown on. And then this one has ties, so I'll tie at the back. Some of them have ties here also that you would have to tie. A little trick you could do is you can tie, if it's long enough, you can just tie it in the front, so that way you don't have to tie behind your back. Okay, so that's tied. Next, I'll go ahead and put my face gear on. So in this instance, I'm going to put on a mask and some goggles. You could also do a face shield that would cover both your mouth and your eyes. So put my mask on. Goggles. And then a set of gloves. So a little trick is putting the cuff of the gown inside your glove. So with this, then the end of the gown stays clean. And we'll go over that when we take everything off. So other one. Okay, so now I would be ready to enter the room and do whatever cares I was gonna do, whether it was getting them dressed, shower, meds, anything like that. So I would be ready to come out of the room, and to take it off, we're going to do the dirtiest first, so our gloves. So we want to do it without touching. So what I'll do is I'll take one hand, I'll grab the middle of the glove and pull it off. Now I'm going to put my finger inside the cuff, because this is considered clean where I tucked it in, and take it off. So those are off the dirtiest. And next I'll take my gown off. So these are disposable, so it's okay that I tear it. So I'm going to tear it and slowly slide my arms out. I don't want to do this quickly because then I'll get the germs everywhere. So that you can touch wherever on the inside that was touching your clothes, because that will be considered clean. So if I tie it, or in this case I'll just break it maybe. You can go over the head as well, just carefully. Then I'm going to wrap it up, throw it away. I'll take my goggles off, and then a lot of times there would be a bin that I would put them in, and we would clean them later on. And then my mask. If we were in COVID precautions, I would put a new mask on after my dirty one. And go throughout the building and then wash your hands. Next we'll touch on hand washing. So hand sanitizer is fine in most instances, unless you're dealing with an organism like C. diff, that hand sanitizer doesn't kill. But you can, kind of the rule of thumb is you can use hand sanitizer 3 times or 3 applications before you actually have to go to the sink and wash your hands. So we'll wash our hands with warm soapy water. We want to make sure we lather for 20 seconds. Rinse, keeping your fingers down, and then when you're drying, make sure, a lot of people have a bad habit of shaking. We don't want to shake your hands so the water goes everywhere, because then you could be spreading germs. And then when we dry, we want to make sure we take a clean paper towel to shut the faucet off. And I suggest carrying like little hand sanitizers in your pocket, because not all rooms have like hand sanitizer hanging on the wall. Gloving, so I'm just gonna go over some times where we would use gloves. So gloves are really to protect, to protect you and the resident. So we'll wanna wear gloves when we're basically doing anything in the bathroom, showering, helping taking them to the bathroom, anytime where you have potential to get in contact with any sort of bodily fluids, when in doubt, wear gloves. So standard pre-steps privacy. So big thing is we want to ensure that all the residents have privacy. So before entering their room, make sure you knock and wait for a response. Wait for them to acknowledge and say come in, or if they say, you know, don't come in, then give them their privacy. You know, if they, in the event of an emergency, then it's okay to go in, you know, fire alarms going off, there's some sort of emergency going on in the facility, then you don't need to worry about knocking and waiting for a response in the event of an emergency. If you're doing a wellness check and, you know, they don't answer, I would just poke your head in and check on them, just to make sure that they're safe. Otherwise, we would want to wait for a response. So post steps, when you're leaving the room, just do a scan of their surroundings, make sure they're safe, make sure they have stuff that they would need next to them if they have a hard time getting up on their own, make sure they have their call light within reach, water, stuff like that, and let them know how they can reach you. So, you know, use your call light if you need anything. So shower assist, in most facilities, they have a shower room. A lot of the assisted livings do have showers in their room as well with a bench. So some people may be independent and some people may need assistance, and that instance will follow the care plan. Each person will have a little bit of a different shower bathing routine to their preference, and will follow the care plan and the service task as well. And it'll indicate how much or how little help they need. You know, some people may just need supervision for safety, so we just need to stay in the bathroom while they're taking the shower. And then others may need more hands-on assistance, you know, like actually washing them, rinsing, washing their hair, getting those hard to reach areas, stuff like that. So a bed bath. A bed bath would be someone who maybe they're unable to have a shower because of a wound, or maybe they're nearing end of life. We would use a basin with some washcloths and put it on their bedside, and then just wash them up really good. A kind of trick is to fold the washcloth up, and then you have, you can kind of, we'll pretend this is a washcloth and it's folded. You would have, you could wash and then you could flip it, and you'd have a clean surface. You could wash, flip it, and then this would be clean. And you want to use many washcloths, you know, at least 2 or 3. You would want to use the same washcloth that you wash their peri area anywhere else. Common sites of pressure sores. So common sites of pressure sores would be the buttocks, the sacrum, hips, shoulder blades, anywhere that they apply a lot of pressure. People who are at a high risk for pressure sores are the elderly in general, and then those who are dehydrated, limited food intake, people who aren't able to move themselves, stuff like that. So those sort of people, we'd wanna, it would be set up in their service plan, and we would turn and reposition them every 2 hours, toilet them every 2 hours. A lot of times they may have a special air mattress, a pressure reducing one, so that it circulates the airflow, so that way it helps with those pressure sores. So we shave with, we will use electric razors. Most of them will be battery or charge. In most cases, each resident will have their own, so that way we're not sharing, and then we don't need to clean in between each use. I shouldn't say that, you still need to clean, but you wouldn't need to sanitize. So after each use, you'd wanna clean the razor, make sure you get all the hair off, just so that way it's working properly for the next person. So, we'll help those. A lot of men shave, and then even the females, as they get older, they'll get a lot of facial hairs. We wanna make sure we help them shave, so they're looking good as well, and to preserve their dignity. So mouth care, if they have dentures, we will take their dentures out and brush them, wearing gloves as if you were brushing normal teeth. And then they would have a denture container, and we would put 1 tablet, denture cleaner, in with a cup. You never want to wash or clean dentures with really cold water or really hot water, because it can really wear on them. So just kind of lukewarm water. We brush them with toothpaste just as you would your normal teeth. And then they would be put in the morning. Some people don't use any sort of adhesives on their dentures, and then some people might use denture paste, or there is denture strips that are kind of act as a glue to hold them in place. And so we want to make sure we brush all that off before we let them soak for the night. Some people might have just upper dentures, some people might have just bottom. There's also such things as partials, or some people might have full sets of dentures. If they don't have dentures and they need help with their oral care, we will help them brush their teeth at least twice a day. Mouth care of an unconscious client, so someone who's nearing end of life may be unconscious, and we still do oral cares. We actually will probably do it more frequently. We might not use a toothbrush and toothpaste just because we don't want them to have to swallow that, but there's toothets, they're commonly green or pink, that we'll use to swab their mouth out to keep it nice and clean and refreshed. Fingernail and foot care. So we will just use a regular fingernail clipper. You can use a bigger one for toenail clipper. Caregivers are allowed to clip nails unless the resident is a diabetic. Then an LPN or RN need to cut their nails, and you would notify the nurse on their shower day that they need their nails cut. And then the nurse will take care of that. Hair care, so whenever we're bringing someone out of their room, I like to do a little look over, just make sure they look presentable. So always make sure that their hair is combed, neat, and clean, just to preserve their dignity. Some people may need more help than others with brushing their hair and keeping it nice and groomed. Dressing assist, again, this kind of depends on the person on how much assistance they need to get dressed. Some people will need no assistance. Some may need cueing or just laying out their clothes to make sure they're wearing clean clothes. And then some people will need full dressing assistance. That'll be on their service plan that the nurse sets up for you to follow as well, and it will have the detailed task on what you need to do to help them. Some people might not be able to use one of their arms or might not have an arm. So when you're dressing, you want to always dress the affected arm first. So let's say my left arm is paralyzed and I was putting my shirt on, I would want to put the shirt on my left side first and then on my right side, just to make it easier. And then when you are taking the clothes off, you want to do the opposite. So undress the unaffected side first, and then undress the affected side. It'll just make things go a lot smoother. Same thing goes for legs as well. Hearing aid placement. I don't have any hearing aids to show you, but I do have some batteries. So hearing aids, there's a lot of different kinds, and each resident will probably have a different kind of hearing aids. Each hearing aid is indicated with some sort of red mark and some sort of blue mark to know which hearing aid goes in which ear. So red is for the right side and blue is for the left side. Some people may only have one hearing aid, and that is just fine. Some people will have batteries to keep their hearing aids charged. A lot of them, they're pretty small, And when they're not working, you know, you'll be able to tell, or the resident will be able to tell you, and we'll put new batteries in. And then some people have hearing aids that are charged each night. So whether they can charge them on their own, or if they need assistance placing their hearing aids on the charger, so that they can be used for the next day. TED or compression stocking application. So that would be in the service plan as well, and it would indicate whether the resident wears knee-high compression stockings or thigh-high compression stockings. So when we put those compression stockings in, you want to make sure that they go to the appropriate place, knee or thigh, make sure they're free of wrinkles, that the heel's in the right place and the toes in the right place. And then people usually, when people do have them, they usually wear them on both of their feet. Bathroom and commode assist. So again, this would be on the service plan indicating how much we need to help them, you know, if it's every 2 hours, if it's, if they just need guidance, you know, maybe they just need help putting a clean pull-up on, that'll all be in the service plan, and we'll help them as much or as little as they need. If they have, a commode is a portable toilet that can be brought, you know, to their bedside. So a lot of times after surgery, if people have surgery or their end of life, they might have a commode in their room, and we would just empty the contents in the toilet and flush it when they were done as well. Urinal assist. This would be most common in males to help them go to the bathroom. A lot of people may use them during the night, so that way they wouldn't have to get up. Peri-care and incontinent resident. So if we have an incontinent resident, we always want to make sure that we get them in a clean, dry, free pull-up or clothes if they wear their own underwear. We always want to make sure we're wiping front to back and using the proper, we don't want to use any harsh soaps. A lot of people will have like peri cleanser or peri wash to use for incontinent episodes. So if we have someone who has a catheter and we need to drain their bag, say a lot of times it's drained and charted at the end of each shift, we will have a graduated cylinder or even a urinal that has markings in milliliters so we can measure their output. So we would measure it on a flat surface again, so you would set it on a table somewhere flat so you could get the accurate output. People want to have at least 30 milliliters of urine output per hour when they have a catheter. So if it seems less than that, it's the end of your shift and they haven't had any urine drainage in their bag, you want to make sure to notify the nurse because the tubing could be kinked, something might be wrong with that catheter. So next we're going to go over vital signs. So for this demonstration I only have the forehead thermometer. So in this instance we don't need to actually touch our forehead, but if I just hold it and push the button, it'll click and my temperature is 98. We'll try this one, turn it on. .9, so pretty similar. Those have gotten really popular, these kind of thermometers. Another common one would be an ear one, where we would put a probe on the end of the thermometer and put it in their ear and pull their ear down to take their thermometer. Those are the most accurate. So blood pressure. I have an automatic cuff for this, so I will just do it on myself. This does have instructions how to put it on, so you make sure that it's on the right way. And then I'll tighten it up. You don't want it too tight, but you want it snug. So when you take their blood sugar, blood pressure, you never want to make sure that their legs aren't crossed because that could affect the blood pressure. This tube that pumps the air should always be like this, so they should be able to grab it. A good way that I remember is there's a big vein flowing through here that a lot of times you can see, so you just would want to line it up with that. And then for this one, all I have to do is hit start and it'll start pumping up. These blood pressure machines will also read a pulse as well. So it takes a little bit, it's pumped up and now it's pumping down. It's just about there. So my blood pressure is 122/70. Not bad. And then it says my pulse is 72. I'm only going to show the automatic cuff for this demonstration, but if you ever want to know how to do a manual blood pressure with the stethoscope, let your nurse know, and I'm sure he or she would be more than happy to show you. Pulse and respirations. So yep, it did just show the pulse on there. There's a few ways we can get a pulse. These oximeters, I'm going to go over oxygen at the same time. These oximeters will also show a pulse. So I'm going to put it on my finger and I'm going to let it sit there. If you do use a pulse off this oximeter, I recommend leaving it on for at least like 20 to 30 seconds because to get an accurate reading. Like right now it says my pulse is 106. But I'm going to give it some time to calculate and it'll probably come down because I don't feel like my heart's beating that fast. So yes, it's coming down. So now it seems to be about 86. And it seems to be staying right there. So I'll go with my pulse is 86. And then you'll have to pay attention because each oximeter will be a little different to make sure that you aren't mixing up the oxygen saturation and the pulse. So right now my oxygen saturation was 99%, but if I didn't pay attention and I just glanced really quick, I could think my oxygen would be 86, which wouldn't be that great. So you'll have to look at, under oxygen it says SpO2, and then pulse rate it says PR. So that's another way to do your pulse. We can also do a manual pulse, so we can find the pulse on the resident, put 2 fingers. I do recommend doing the full minute or even counting to 30 seconds and then timesing it by 2. I don't recommend doing the 15 seconds and then timesing it by 4. You're not doing it long enough and then there's more room for error when you're timesing it by 4. So to do the most accurate, I would do 30 seconds and times it by 2 or a full minute. Weight, each facility will have may have a couple different scales. We can just use one of these scales, make sure it's cleared before they go to step on it, and always weigh on a hard surface. Don't weigh on carpet because there will be a discrepancy. If they are wheelchair bound, we can weigh them on a wheelchair scale. So what we'll do is if we weigh them a lot on a wheelchair scale, we might have the weight of the wheelchair on the back. So that way when we go to put them on the wheelchair scale, we can just subtract the weight. You want to make sure that if they have foot pedals, that we're weighing the wheelchair with the foot pedals or without the foot pedals. And then we would just subtract the total weight from the wheelchair weight to get the resident's weight. So next we're going to go into some mobility stuff. So I'll grab the gait belt and I'll show you how to put a gait belt on. So gate belts would be used for our 1 or 2 assist transfers or ambulation residents. So I'll just put it on myself. So you'll put it around their waist. Put it through the loop, tighten it up. It may be tight when they're sitting down, if you're putting it on when they're sitting down, but then when they stand up, it'll loosen up. So I put it through, I got it snug. I'll loop it through again. And it's on. This is just mainly used so it's easier on you, but then we're not pulling on their arms as well and their armpits. So we'll always, let's say we're gonna walk someone, we'll always walk slightly behind them, just half a step. And then when we grab a gate belt, we wanna grab it from underneath. So that way if you needed to catch them, you could. You don't wanna grab it like this, because then they could slip out of your hand really easy. So underneath. And then if you had 2 people, you probably have 1 person on each side grabbing the belt. The only instance where we would have it higher, like this, is if they had like some rib fractures or something, or an abdominal binder, something like that. Otherwise, we'd always want it lower, little slightly above the waist. Supine position. Supine position is just when someone's laying flat in bed. They're not laying on their side. They could have their bed up a little bit, but they're just laying straight in bed. And then sideline is if they are laying on either side. We might put a pillow in between their knees so that way they don't friction and rub together and get a sore. Or we could put a pillow behind their back so that way they couldn't roll over as easily. Moving someone up in bed. So for moving someone up in bed, we would probably have what we call a transfer sheet, and it would be their mid-back. So that way we would have 1 person on each side of the bed. We would want to make sure we count to 3 so we're working together, and we would slide them up. So 1, 2, 3, and then we would each grab the side and slide them up in bed. If we have to so if we need to make, say someone is bed bound, so they're end of life and we need to make their bed. They've soiled the bed and now we need to change their sheets. We will roll the resident from side to side and tuck those sheets. So I would put the bed on 2 corners, I would tuck it under them, and then you would want help with this. It'd be a tough job to do by yourself. You would roll the resident towards you, and then that other person could grab the other end of the sheets and put the sheet on the bed. Feeding a client. So if someone needs help with feeding, we're going to want to make sure that we aren't feeding them too fast. They could throw up, they could aspirate, and then we want to offer fluids, so whatever they have to drink, water, juice, or milk, after about every 2 to 3 bites. Offer them a drink. Even if they take a sip at something, then they can wash everything down, and that prevents them from pocketing food in their cheeks. So if someone ends up choking, and you can see it, it's okay to swipe your finger in their mouth. That would be a conscious client. If you have some sort of body fluid spill kit, so blood or vomit, each facility has these kits to help clean up. So there's some powder, a red bag in there for anything biohazard, gloves, stuff like that. And it shows you, it has everything that's in here, and then it gives you clear directions on how to use if you need to clean anything up. Each facility has an eye wash station. Each facility has a different location of it, so that'll be site specific. Each facility has different call light system as well, so you'll learn that on your site as well. I believe that is it for the skills orientation.